All right. Well, welcome everybody. Thank you so much for joining our webinar today on how to negotiate better contracts, strategies for success. My name is James Muir. I'm going to be your host for this session, and this is easily the highest number of registrations that we've had for any webinar to date. So we're absolutely thrilled to have you with us. We're looking forward to an engaging and informative session. Before we get started, let's just go over a couple of housekeeping items just so that it's a smooth and experience for everybody. So all the participants will be muted during the presentation so that we can minimize the background noise. And we will have a dedicated Q&A session at the end of this presentation. So you can submit your question using the Q&A feature in Zoom anytime you want. We can do those. And if we can, we'll incorporate that live as we go through the session together. If not, we'll pick it up at the end. It's obviously a very hot topic, so we're going to do our absolute best to address as many questions as we can during this session. This webinar is being recorded and it will be made available to all the registered participants after the session. So you're going to receive an email with the link in it to the recording, as well as some additional resources that we'll talk a little bit about during the presentation. And so now, without further ado, let's dive into today's topic. That is payer contracting. And it's obviously a very hot topic right now. So I thought to myself, who can we invite to Unislink to educate us on this topic that's going to be the absolute best? And that person is Nathaniel Arana. And he's the managing partner of NGA Healthcare. So join me in welcoming Nathaniel, who's an expert in payer negotiations, among many other things. And for those who don't know him like I do, I'll give you sort of a quick bio. Nathan he's got decades of experience in the healthcare business. He got his MBA at the Eller College of Management and launched a thriving out-of-network billing and consulting business all the way from concept to profitability. Nathaniel started NGA Healthcare precisely because he found that practices are desperately seeking help with their declining payer contracts, which we're going to talk about today. And since establishing NGA Healthcare, NGA has worked for over 70 different specialties, ambulatory surgery centers, you name it, to help them improve their contracts and help their organizations get more profitable. And so you may have seen some of his writing because he's a regular contributor to a whole bunch of business magazines. He's an expert in payer contracts and practice management. So on a more personal note, what I can tell you is that he and I are cut from the same cloth. We both have family in healthcare, and he believes, like I do, that we really need to preserve the practice of independent medicine. And one of the best ways of doing that is to make it possible for them to compete with all the big guys by making them more profitable. So you're going to see right away that Nathaniel is a wealth of knowledge. So enjoy your time with us today, Nathaniel. I keep calling you Nate. Sorry, trying to keep it formal. Thanks for being with us.
No, thanks for having me. And Nate, Nathaniel, either of them works. I've been called worse, so no worries.
Well, as evidenced by the number of registrations that we got, this is an extremely hot topic right now. Last time I checked, adjusted for inflation, physician reimbursement for Medicare has dropped somewhere around like 26% or so since 2001. So literally it goes down year after year after year. And that is just nuts since a lot of commercial contracts are based on CMS, right? So that's a bad outcome. So everyone is interested in how we can stop that hemorrhaging and how it can actually improve our commercial payer reimbursement. So with that frame, we're hoping you're going to educate us a bit. And to kick us off, what I thought we would do is maybe just ask the audience a poll question. So if you can tee that out for us, Katie, that would be great. The question is just, simple question, have you negotiated your rates within the past 3 years? Yes or no? So getting to the frequency, and then we're hoping that you'll illuminate us on how frequently we ought to do that, Nathaniel.
Sure.
Give them a second to answer, and then Katie will flash up the responses to us, and then we can judge. Do you want to take a guess before we see the responses, what you think you'll see?
My guess is probably 95% of practices have not negotiated their rates in the past 3 years.
Okay. Well, let's give a couple more seconds, and then if you can show us, Katie, we'll see what we get. Oh, it's a little bit better than that. It looks to me like 70%.
Okay, not bad.
So maybe Unisync people are, are.
No, we have a very sophisticated audience then, and that's a good thing. So,
All right. Well, with that little frame, why don't you educate us a little bit?
sure, and as you mentioned, not a lot of practices have negotiated their rates in the past few years. And the reason that that can be very difficult is, not just because of inflation, but if we look at the climate now and how we are with inflation and cost of doing business, it's astronomical how much those figures have increased. Let's take an example. Let's forget, inflation for a quick second, and let's just look at the increase of wages that not just clinical but also administrative staff are commanding. And that's not just trying to find current employees to provide those services. That also includes um, future employees. For example, if you're trying
Right.
to recruit for medical assistants, front office staff, billing personnel, whatever it is, they're asking for wages that are, 20, 30% higher than they were just a few years ago. Then you put in inflation, and we know what the inflation has looked like. And all of us have gone to the grocery store, of course, and have seen the price of things increase dramatically. The problem with the medical practice is that they're not like a grocery store. They're not like a retail store. They're not like any other business that can simply just increase their prices. They can't do that. They have to go to their payers and say, hey, we're not making the margin that we need to, or we're not profitable. We need to increase our rates. And that's the whole thing about inflation is that if you're not negotiating your rates on a yearly basis, and yes, we really encourage our groups to negotiate on a yearly basis, then you're usually losing money year after year. So if we say that the inflation rate is, let's give it a conservative estimate and say it's 5%. If you haven't negotiated and the inflation rate is 5% a year and it's been 3 years, well, you're actually making 15% less than you were 3 years ago compared to today. So if you're not keeping up with that increase in inflation, you're really, really losing money. And the cost of doing business is increasing in addition to the inflation. So it really stacks the cards against you as a practice if you're not negotiating those rights on a continuous basis. Let's look at the example of large healthcare systems. They always negotiate their rates every year. I think all of us have seen those news articles where they say so and so health system is no longer going to accept Blue Cross Blue Shield as of April
Right.
1st. And we know that those health systems are entering into pretty large negotiations with a number of these health plans. And the reason for that is because these large health systems have a lot more leverage, of course, and we'll get into leverage and how small practices have more leverage than they think a little bit later on. But basically, you'll see large health systems that are getting a large reimbursement rate as compared to an independent physician practice. So the way that we kind of look at reimbursement rates is we do them as a percentage of Medicare. We say, okay, there's a physician, a cardiologist A who's in, let's say, Phoenix, Arizona, and they're getting 95% of Medicare. Well, you have to keep in mind that some of these health systems are getting 300, 400, 500% of Medicare. And it's not good for you and I, the consumer. It's not good for independent practices for these health systems to get reimbursement rates that are this large. There's a reason why, if you go to an independent diagnostic facility, to try and get, let's say, a CT scan, and let's say you have a high deductible, it's going to cost you, maybe $600. But the same service at a health system is going to cost you $3,500.
Hmm.
And that's the reason why we really need to focus on negotiating reimbursement rates, focus on putting the value in the independent physician groups who can perform the exact same services with better quality, better clinical outcomes at a cheaper rate. And we have to educate the public on that, number one, but also we have to ensure that we are supporting these independent physicians so that they do remain independent and don't become part of these large health systems or large private equity systems. That's not to say that there isn't some sort of room in the healthcare industry for private equity to help some of these independent physicians. That's, not what I'm trying to argue here. There are some private equity companies that are very good at providing the management support that some of these physicians need in their business, but there are some that aren't so good. And a lot of them regret kind of signing up for private equity because they find out it's the wrong partner. They're focused more on the revenue, not necessarily clinical outcomes, the patient experience, etc.
Hmm.
So we like to see that independence, and we like to see what we like to call is the law firm model for physicians. So in law, oftentimes, and of course there are instances where this doesn't occur, but for the most part, when you're a student who has gone to law school and let's say you pass the bar, you enter into a firm as an associate. And over time, as you are taught didactically by the partners in this firm who have many years of experience, you start to learn the law, you start to learn your craft, you start to learn your specialty, in essence. And eventually, you become a partner yourself. We like to see the exact same model in healthcare. We like to see either a single specialty or multi-specialty group bring on board a physician as an associate. Let's take an ENT group that has 7 physicians and they bring on 3 associates, and 4 of the physicians are partners. Well, we like to see a situation where those physicians are teaching those associates, the partners are teaching the associates didactically about ENT and things that they've seen over the years. There's just no, better situation than to have somebody as a mentor like that who's teaching these physicians, who's guiding them towards practicing great medicine. And those are the types of places where you want to be seen, and those places are often, very often independent. And it's in stark contrast to a lot of these large health systems in that the large health systems are being run by people with MBAs, whose primary focus is not necessarily the patient experience, not necessarily clinical outcomes, but rather the profitability at which they can achieve. And that's not good for the patient, and that's not good for society in a whole. And this
100%. If I can add a little bit to that, we did a webinar a few weeks back on physician burnout. And the interesting fact that plays very well into what you were just saying there is these independent practices, they actually, on average, they earn about 20% more than the employed physicians do. They have a higher degree of control. They feel like they have a better, degree of control, and they have the highest job satisfaction over both private equity and hospital-owned physicians. So it's the sweet spot. It's better for patients. It's better for doctors, and it's lower cost care overall.
Yep, exactly, 100%. So this chart just kind of shows us, something that I think we all know, which is that, we're spending way too much on healthcare. And if we look at that figure of, per capita, $11,946, compared to a comparable country average of $5,736. Why is that occurring? Well, we have the answer. It's the health systems. It's the ones that are getting 300, 400, 500% of Medicare, those $3,600 CT scans. That's why we see that um, occurring. And to really understand the context of why things are working this way, we really have to look at um, who's really controlling the money, who's controlling the purse strings. And the short answer to that is the payers. There is a law that was passed in the earlier part of the last century called ERISA, which is the Employee Retirement Income Security Act. And what that law demanded was, and let's go back to why that law was even implemented in the first place. It was implemented because I don't know if you guys will remember, but I'm not dating myself, but a car called a Studebaker, which was a really cool looking car. And they were manufacturing that car for many years, and they had many employees, and they were paying into a retirement system. But come to find out, some of the people on top were doing as they pleased with that retirement money. And when the company went bankrupt, there were thousands of workers who had thought that they were saving for their retirement their entire lives, but they weren't. And obviously, they didn't get any of their retirement. And so that sprouted the Income Retirement Security Act that dictated that whenever a company is providing some sort of benefit, including a 401k, health insurance, they have to be acting in the best interests of the patient. Now, what does that mean? Well, we'll leave that up to interpretation. But healthcare was included in that legislation because so many companies offer health insurance to their employees, and they have two options. They can either do what's called self-insured, or they can do what's called fully insured. So fully insured, what you do, let's say you're a small company of 20 employees, you're a medical practice, you go to Blue Cross and you say, hey, we need health insurance for our employees. They say, great. It's 500, 600 bucks an employee per month. We'll deal with all the risk. There are larger companies, generally 50 and more, that are self-funded. And what that means is they create their own pool of money and they pay out from that pool of money their own claims. And Blue Cross is just the intermediary. They're the TPA, which stands for third party administrator. And their job is to administrate that money in a very judicious way and in a way that they have fiduciary responsibility. So I would argue, is it very, are you acting in the best interest of your employees if you're paying some of these health systems 400, 500%, and yet you can get the service at an independent physician practice for a fifth of the price? I would argue that, that's not necessarily working in the best fiduciary interest of the employee. And we've seen what's going on out there because some of these contracts can be very lucrative for these insurance companies. So they're paying, large kickbacks to brokers that are bringing these employer groups into health insurance. As an example, Blue Cross Blue Shield um, spent $816 million on broker bonuses and commissions, 3% of its revenue. So why are we as medical practices arguing about reimbursement rates when we can't even get these insurance companies to pay us a fair rate, but yet they're paying one of them is paying nearly $1 billion in bonuses and commission. It just shows you guys how kind of broken our system is.
Truly.
But we want to, talk about how we as physician practices can negotiate those rates, and I would like to get into that subject. So it's very important that, again, as I mentioned earlier, that you're negotiating your rates on a yearly basis. And this slide here, it shows you kind of the vertical integration between a number of these insurance companies and what their how they're integrated into every part of the healthcare process, not just the health insurance part, but also the pharmacy, et cetera. We all know that Aetna owns CVS.
Mhm.
United Healthcare has Optum RX. A lot of them are robbing Peter to pay Paul, so to speak. But you guys can see just by this slide how they're very integrated into the entire system. Uh, so again, this is another slide that I like to show to people, just showing the average reimbursement rates versus inflation versus the operating costs of a practice. And as you can see, it's inflation has increased, operating costs has increased, but yet the reimbursement rates have not. So begs the question, how do you negotiate your reimbursement rates? Well, the first thing you need to do is understand that if you just send a letter to the insurance company saying, "Hey, my rates are too low. I need an increase." In all honesty, that letter will probably be put into a black box and will never be seen again. It really takes, if you guys have ever heard the saying that the squeaky wheel gets the oil, it really takes being a squeaky oil, excuse me, a squeaky wheel. And the reason for that is because while it may be important to you as a practice, a 10% increase, it's a drop in the bucket for a number of these insurance companies. It just takes trying to convince them to move in the right direction every year. And how do you do that? You have to demonstrate how you are a value to the network. How are you saving money? You have to point out those things that we've discussed earlier about how you are an asset to the network, not just because you're a fifth cheaper, but also because you're keeping patients out of the emergency room. You have some sort of a novel service that a lot of your competitors or the health systems do not have. Whenever we negotiate with insurance companies, we put together what's called a value proposition. And what that value proposition does is it demonstrates how a practice is different than their competitors. It demonstrates how they keep patients out of the emergency room. It demonstrates how they keep patients from continuing to see different types of providers for their ailments. We demonstrate how we shorten the episode of care. For example, if we're a dermatology practice, and perfect example of this is we had a dermatology practice that was in New York, and they had a relationship with the local hospital systems. And keep in mind, this dermatology practice was in a very underserved area, in places like Harlem, where there aren't a lot of dermatology practices, and where patients don't often have an established dermatologist. And so they had a relationship with that hospital system to where if a patient presented to the emergency room with cellulitis, whatever other dermatological ailment, they would call up this dermatology practice and say, "Hey, we have this patient showed up at the ER with cellulitis." And they'd say, "Great, send them over our way. We have a slot waiting for them." So they would proactively uh, uh, take in these patients who otherwise would have gone into the emergency room.
Mhm.
And, how fair is it that, these patients would have had a $5,000 bill at the ER, but instead they were never even admitted to the ER in the first place. They were sent directly over to the dermatology practice. The dermatology practice kept slots open, for these patients.
Mhm.
And, think about how much money that they were saving, not just for the health system, or excuse me, for the insurance company, but for society in general. And so, how fair is it that you pay that provider, and they were making 50% of Medicare, believe it or not, because, New York is a tough market. How fair is it that you're paying them 50% versus the 400% that the health system would have gotten had they seen that patient? It's not equitable. So, that's one of the arguments that we often make with these insurance companies is let's really look at the pragmatic and day-to-day things that occur uh, on a daily basis, and let's make sure that we're incentivizing the right groups. And that's a very good example of how that should absolutely occur in this circumstance. You shouldn't be paying a group like that 50% of Medicare if they're actually saving you, you know, tens of thousands of dollars
Right.
every single day. Uh,
So we got a question just on this, and maybe you're going to cover this in just a second, but the question is around, so how do they differentiate themselves? What are some strategies that they should use to look at to try to differentiate themselves and justify their requests during negotiating? And you're welcome to pick up that later. I just throwing it
yeah,
out there about that.
no, absolutely. And that's a very good question. The majority of what you should really demonstrate is cost savings. How are we saving the system money? In this example of the dermatologist, obviously you can say we're saving you money because we're preventing emergency room presentations. But it doesn't just have to be that. Let's say you're an orthopedic surgeon using, the Da Vinci system that we have shown has better clinical outcomes. That's another example where you can say, look, we're saving this much because we're stopping readmittance of patients due to complications because this surgical device is so precise. Another, perfect example is let's say you're a vascular surgeon and you're preventing patients that otherwise may lose a limb. We know the costs of losing a limb, and forget what it does to the patient, of course, but just the actual direct costs in the medical field of what a leg amputation is going to cost is exponential versus a good vascular surgeon who is treating patients very holistically. Another good example is when you enter into multi-specialty situations. We know, for example, that when podiatrists and vascular surgeons work together, there's better clinical outcomes, and it saves us money. Proper wound treatment, um, creating slots for patients that otherwise would present to the emergency room. Just any example where you're adding value to a health insurance network is a good thing to present to them to say, hey, I'm doing this for you. And I don't necessarily have to do them. I don't have to do it that way, especially not the way you're reimbursing me, especially not the way that you're making me do pre-authorizations and jump through hoops to get paid. There's just several ways that you can demonstrate that you're creating a cost savings to their network.
Nathan, does that vary by specialty quite a bit, or are there common strategies that you can see that work kind of across all different specialties?
I think that there are common strategies that work across different specialties. I've given some specialty specific examples, but every single specialty can always demonstrate how they keep patients out of the emergency room or how they keep patients from getting readmitted to the hospital. Those are the major things. Again, we discussed earlier about how some of these health systems are getting 300 and 500% of Medicare. That's precisely why we want to really hit it home and say, hey, if we're doing an E&M, evaluation and management of a patient at $150 versus them going to the hospital for $5,000, what's the difference if you pay me $180 for that evaluation and management? So it's that cost differential that we really, really want to hit home with a number of these.
Is that the only thing the payers listen to, or are there other dynamics besides that?
Well, I hate to kind of sound pessimistic, but at the end of the day, what do payers care about? They care about their shareholders, uh, and that's basically it. But on a more granular level, where are they getting their revenue? They're getting their revenue from their employer groups. They're not getting their revenue from patients. They're not getting their revenue from physicians. Those are just a cost to them. So at the end of the day, do they necessarily care about the patients? Do they necessarily care about the physicians? My argument is a lot of them don't. Unfortunately,
Mhm.
care about the employer groups. And that's just kind of the reality of the society that we live in. That's where their revenue is coming from. And that's who they're going to listen to. So we've had situations where if a negotiation isn't going as we expect it to be, and we don't feel like the insurance company is actually acting in the best interest of the practice, sometimes we'll go to the patients and we'll say, hey, we've been trying to negotiate with this insurance company for a year or whatever it is, and they're not working with us. And they've been paying us the same rate for 15 years. And if we don't get our rates increased, we're going to become part of this larger health system. So we need you to go to your HR, your human resources, and explain to them what we've been trying to negotiate these rates. And we've been unsuccessful thus far. They're not listening to us, they're not responding, they're not moving in the right direction, whatever it is. And oftentimes that is enough to move the needle. Um,
Now, it seems like that it's pretty easy to make a case if you have transparency into all of the different reimbursement rates that are going on in a given market. So can I ask you, how do you know, or how do you get transparency into, if you're working for a client and you're trying to improve their rates, how do you get transparency into the rates that are being paid in a given market?
that's a very good question. And we used to have our own internal data, and we still do, of what, specialties were being paid across the country. We worked with so many specialties that we had a pretty good idea of what those rates look like. But about a year and a half ago, the federal government passed a law, a transparency law. First, they passed a hospital transparency law, which made it so that all hospitals had to publish their rates. Bear in mind, to this day, only about 5% of them are actually compliant with the law itself. But shortly thereafter, they also passed a law that insurance companies had to publish the data of what different physician groups are being reimbursed. But these insurance companies understood that if they did that, it would dismantle this entire system that they've created where they're able to pay physician A $100 versus physician B at the health system $500. And so what they did was they released the data, but they did it in such a way that was many, 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 many terabytes of data that was, for all intents and purposes, very difficult for anybody to actually navigate and really understand and really use. So very similar to when there's a large, lawsuit, they basically do a data dump and they say, here, you figure it out. And that's in essence what they did. And we've partnered with a number of companies that have, multi-million dollar servers that were able to comb through this data. So we're fortunate enough to know that when we bring on a client, we know how much their competitors are making. And we very often use that information in our negotiations. And we say, all right, I know you're paying physician B down the street. I know you're paying them $500. You're paying us $100. Let's work towards moving in the right direction. So data is very, very important to us. We not only use our own internal data from our negotiations to understand where we should land, but we've also partnered with some great companies that can, comb through that data and really help us to understand what the market actually looks like, what you actually should be getting paid.
Is that data publicly available, but just basically hard to use, unusable?
Exactly. It's
Where
publicly available, but hard to use. I mean, we've downloaded it. It took us a couple of weeks to download, one insurance company, and that's just, they're trying to make it difficult to usurp, in essence, the use of it. But, fortunately, we've been able to work with some great companies that have been able to crack that code.
Incredible. Well, I want to keep us on course here, but we're getting a lot of questions here, so I'll let you keep going here. But lots of interesting questions. You want me to just go through these, or do you have some?
Well, I do want to let's go through those, but let me just go through one last quick tip when you're negotiating your rates, because I think that this one is really important. When you're negotiating your rates, don't ever take what the insurance company is saying as literal. And what I mean by that is there's an example where I was working with a neurology group, and they had been negotiating their rates on their own, having a little bit of difficulty. Nonetheless, they said, "Hey, we're having a little bit of difficulty. We want you to take over." I said, "Great." They said, "We've already negotiated a 10% increase, but I think we need it to be more." And I said, "Okay, let me see the offer that they're giving to you." So I looked at the offer, and as a neurology practice, all the neurology codes were being decreased. Uh, all the codes that were related to things like cardiology, dermatology, those were being increased. So in essence, yes, it was a 10% increase, but not for codes that this practice was going to use. Insurance company was just, in essence, fooling them. And I called them out on it. And, we got an actual 20% increase on the actual codes themselves. So the other major tip that I really want everybody to look out for when they're negotiating their rates is that you have to look on a granular level on each and every single CPT code. So if you're a dermatologist and you have 11017 for doing a biopsy, well, look at that rate and see how much is increasing or decreasing compared to the E&M codes. Sometimes they may say, "Oh, well, we're going to decrease your E&M codes," and that may not necessarily be a bad thing as long as you look at the other codes and make sure that those are increasing and making up for the decrease in those other codes. So very important that you look at every single CPT code, you weigh it, you times the CPT code reimbursement amount by the number of encounters that you have in a year, so you can get a weighted amount of what you're actually going to be reimbursed.
Great
So,
tip.
yep, absolutely, and I'm happy to go through any of those questions.
Yeah, so and there's so many here. I don't know if we'll get through them all. So I think I can get three for one here if I just throw out here. Apparently we have a decent number of behavioral health groups online, and so at least three of them have asked. Yeah, it's difficult as a behavioral health group to differentiate. So do you have any ideas specifically for behavioral health in terms of how to differentiate when you're negotiating with payers?
Actually, behavioral health is an example where there's a lot of really good examples where they can differentiate themselves. Major one is emergency room presentations, suicidal ideations. Those can be very, very costly presentations to the emergency room. So you can make an argument very easily that, you're stopping a lot of those emergency room presentations. The other thing is we've done our research on this, and we know that for every dollar that is invested in behavioral health saves the system $7, which is absolutely incredible. And it's very telling how important behavioral health is to our healthcare system. So there are many, many examples where behavioral health and having the right support, having the right clinician, um, can differentiate themselves. We did a negotiation very recently where it was a behavioral health clinic, and what they did was before a patient ever entered into their program and were assigned a clinician, they would try and determine who the best clinician for that patient would be, because we all know that patient compliance is going to be better if they like their clinician. So they were doing that, and because of that, we could show, hey, we have patients that are on average 20% more likely to remain within the confines of our program and not present to the emergency room as a result of us getting them with the right clinician. So behavioral health is a big one that we can show that there are many different things that can save the system money, and it's advantageous to have them in within a health insurance network.
Good. Great tip. And if you happen to know if there's a publicly available source for that 7-to-1 ratio on behavioral health, that's fantastic. If we could figure it, but maybe we'll talk after this. We'll find the reference and we'll send it out as one of the goodies after we send the recording. All right, so let me see if I can chug through some here. So can you talk a little bit about the timeline? And so there's several questions around that. How long does it take? How often should we engage? How do you how do you engage with the payer in a way where they're responding in a timely way? I'm getting questions around that.
Yeah, no, absolutely. A lot of our negotiations can take anywhere between 6 to 8 months. Sometimes it can take longer. Um, of course, you have situations like with United, as an example, where you have a 3-year contract and you can't necessarily negotiate until you reach that 3-year mark. But in general, you're looking at between 6 to 8 months. It's not a fast process by any means. Once again, we want to come to the negotiation table with the most amount of information that we can possibly get. So we always benchmark our rates, and what we do within that benchmark is we look at the different payers, and we look at, obviously we have our own data and we have our own data from the health insurance companies, but I like to see, for example, if we do a payer mix and we say, all right, United Healthcare is paying us 110% of Medicare, Aetna's paying us 105%, but Cigna's paying us 80%. Well, that tells me that the market can bear anywhere between 105 and 110%, maybe even a little bit more. So that's when you go more aggressively to Cigna and say, hey, you're paying us 80%, which is nearly 25% lower than what your competitors are paying. So we like to do a payer mix in order to understand what we should really be asking for and understanding where we should really be landing.
So you hit on an important thing there. What about tying reimbursement rates to Medicare? Is that okay? And if you do, do you have any suggestions or tips around how to navigate that?
Yeah, we always use Medicare as a benchmark. There's a published list on CMS, and all you have to do is just Google CMS CPT lookup. And what that does is that gives you the Medicare website that publishes every single CPT code rate within a specific region. Medicare has very specific regions. Sometimes it's statewide, sometimes it's region-wide. If it's a larger place like Texas, they break it up into quadrants. And I always like to use Medicare as a benchmark, not just because it kind of gives us an idea of what we should be paid, but bear in mind that over a decade ago, Medicare used to be the poorly paying payer, and commercial insurance was usually a lot higher than Medicare. That dynamic has switched to where Medicare is the highest paying payer, and these insurance companies are trying to pay way below Medicare. So we like to use Medicare as a rate that we can cross-reference and check with.
Even would you say that's true even if it's a fraction of the typical reimbursement rate? So instead of being 1-to-1, let's say you're typically even half of Medicare, which would be really low, but you'd still use Medicare rate as the reference, right? Because
Yeah.
you're trying to get from half to 75% or something like that. Yeah.
Yep. That's why we like to use Medicare as a reference.
Okay. And you mentioned getting the information, which is publicly available online, so you can see how much. But you do need to pay attention to the regional area. There's something called the Gypsy um, that they reimburse differently depending on different areas. So, all right. So let me, man, there are so many. We are never going to get through all these. What is a typical increase for a client? So that now I don't. When let's just say when you're doing a negotiation, okay, what is a typical increase for a client when you take the time you negotiation with a payer and 6 months and 7 months out, you've got an increase of some kind. I think what they're trying to ask here is the juice worth the squeeze?
Yeah. Well, it is. And well, we would typically see anywhere between 10 to 20%. But the important thing to know about that 10 to 20% is that it hits the bottom line immediately, meaning that you don't have to see more patients. You don't have to provide an additional service. You don't have to imply more resources. It goes straight to your bottom line. It's complete margin because you're not changing anything except how much you're being paid. So, adding 10 to 20% to your bottom line, it makes a big difference. It makes a huge difference. So it is worth the effort, in my opinion. And again, we see 10 to 20%. If you haven't negotiated in 15 years and you're 50% lower than your competitors, are we going to make up that difference? Probably not. But let's at least move in the right direction and get an initial increase and then continue negotiating every single year thereafter to try and make up not just for those losses over the last 15 years, but also the continuing inflation.
Okay, related question to leverage and differentiating. Basically, the question is, I'm a smaller practice. What's a good way for me to differentiate even though I'm small? So, um, similar to what we talked about before, but just giving you another angle at it.
Yeah, and we get this a lot of times. A lot of times we'll have a practice, they'll say, "Oh, I'm an independent physician. There's only one of me. What leverage do I have? Are the insurance companies going to even bother with me?" And the answer is yes, because there's been so much private equity buyout of these practices. A lot of these insurance companies, a lot of these payers are understanding that we have to negotiate with these independent groups because otherwise they're just going to, uh, join these large health and hospital systems. So even as an independent physician, you can say, hey, either you work with me or I'm just going to join this health system. And instead of paying me 80% of Medicare, you're going to be paying 500% of Medicare. A lot of these insurance companies are working with these independent physician groups. And I can tell you that our independent physician groups, where it's just one physician, do we tend to make a lot of money on those? No, but that's okay. We still bring them on board because we want to make sure that we're helping those groups out because they're the bread and butter of our healthcare system. And again, we already know that independent physician groups have better clinical outcomes. So they may not necessarily have a lot of leverage, so to speak, but it's not always about leverage. It's about, negotiating, keeping them independent, etc. I can make the argument all day long. And not only that, but it's much more difficult if we're representing a group of, let's say, 300 physicians, and we're trying to get a 2% increase or a 5% increase. That's a lot of money for a group that large. But if it's an independent physician and we're trying to get 20%, it's not that much money. Not to the insurance company anyway. It's going to be very meaningful for the independent physician, the solo physician, but not to the insurance company. So we still take on those negotiations, obviously, and they're again very vital, for us to do those and very important for us to do those.
So let's do a couple more of these, and then I want to give you a minute to talk about how you go about it on your side. So, but one of these interesting questions that I just got here is, are there other things that can be negotiated rather than reimbursements? I mean, what kinds of things can you actually negotiate in a contract besides reimbursement? I know that's the most important thing probably, but are there other things, other dimensions to the contract?
There are certainly other dimensions. as an example, we can negotiate how long that contract's going to last. Typically, when you get into things like how long do they, pay a clean claim, or what's the timely filing, or what, typically those are pretty non-negotiable. But reimbursement wise, you can always look at negotiating things like carve-outs, for example, if you're doing something novel. An example of that is we have a number of interventional radiologists who provide Y90, which is yttrium 90, which is a targeted chemotherapy for cancers that have spread to the liver. And that's typically done at the hospital at a cost of, 80, $90,000. Well, an interventional radiologist can provide the exact same service uh, in an office-based setting because it's just a venous procedure that's non-invasive and not dangerous, or less dangerous, I should say. So we've gotten negotiated contracts where we say, all right, the cost of this medication is $20,000. We need you to pay for the medication if you want us to perform it in the office-based setting at a fraction of a cost. And a number of insurance companies did agree to that. So that's more lucrative for the physician. They get paid more, the hospital gets less, the patient pays less, etc. So there's a lot of different things that you can negotiate within a contract. Some are a little bit more difficult to do so, but some, especially this example I just gave is a good example where, it makes sense for the insurance company to do it.
Well, tell us a little bit about, and guys, we have so many questions here. I can't get to them all. So I promise what we'll do is we'll get them all cataloged down. We'll get you some answers, and then we'll send them back out to you directly, or we'll create a frequently asked questions doc and send this out after the webinar is over. But Nathan, I want to ask you just tell us about the NGA's approach to contract negotiations. Like if somebody on this call wanted to get some help because it seems overwhelming to them, how do you approach it? What's your model? That kind of thing.
I would say that our model is absolute consistency in that whenever we enter into a negotiation, and this goes for anybody who wants to negotiate their own rates, you have to be consistent with your follow-up. So we have project managers on our team whose sole job is to just follow up with the health plan on a very consistent basis and say, hey, this is our request. What's going on with our request? Is this going through, the right venue? Is this going through the right departments? What's the status of this? If you just send it and hope for the best, nothing is going to happen. So our secret sauce is the consistency, of course. We have a number of employees who used to work at the health plans as contract negotiators that have joined our team, and they like to say that they've joined the light side. Uh, and just understanding the dynamics and the red tape that exists at the health plans. Understand that these are very large organizations with thousands and thousands of employees, and to get something done, you have to be consistent in your follow-up.
So if someone, so in my mind, that's why I would hire someone to go do it for me because I don't have time to do that. If someone hires you, what's the approach that you take? Tell us about NGA. And I don't want to steal your thunder here. I know a little bit, so but we're short on time, so I'm hoping you'll give us the NGA value prop here
Yeah,
toward.
sure, absolutely. So we actually put our money where our mouth is, and we guarantee that we're going to provide you results. We do, charge an initiation fee, and then we charge a percentage of the value that we give for a previous baseline year. So let's say that, Blue Cross paid you $100,000, and under a new agreement, we're able to get them over the past year, and we're able to get them to pay you $130,000. Then our typical fee is a third of that fee that you guys pay over time so that it doesn't, affect your cash flow. If you work with us and we get you nothing, then we return our initiation fee. So we're confident in our capabilities and that what we do is we say, hey, if we don't get you any results, you're not going to pay anything. Um, and that's the model that I've always wanted to have because I've seen so many groups out there that say, well, I work with a consultant and they, charge $500 an hour or whatever it is, and it's been 6 months and I've seen no progress, I've seen no value. That's not the way that we run our business. We put our money where our mouth is. We put our capabilities on the forefront because we know that we're the best at what we do. So that's our value proposition in essence is you're only paying us if we're making you money, which I think is a pretty good value proposition.
So I've had the privilege of working with different consultants over the years. You're the only organization I've met with that will do the whole thing on a contingency basis. So I think that's a real merit to your organization. And I think we may have a QR code that you can pop up, but if they want to contact you to get some help, or at least just have a conversation with you
Yeah.
about what's that like, how do they contact you?
You can either email info@ngahealthcare.com or go to our website, ngahealthcare.com. We have links in there where you can set up complimentary consultations, whether you work with us or not. We have team members that can walk you through what we do and how we do it. And if you decide to work with us, great. If not, that's okay too. We're always happy to fight the good fight and help, our number of groups out there to help, negotiate their rates.
So I think there may be a slide at the end of the deck somewhere where they can take a picture of, yeah, there you go. Thank you. So the one on the left is for NGA. That's Nathaniel's group. And you've got their website and then an email address there. So if you just take a picture of that and you'd like to talk to any of his people, you can from there. Some folks were given a promotion, or if they would like to get an assessment, where NextGen will help analyze your rev cycle. That's what the QR code is on the right, is your Unislink RCA. So if you receive that, you can snap that, put your information in there, and then there's no charge for that assessment. So we've only got 2 minutes left. Give us some final thoughts about payer contracts and negotiating better contract rates.
Yeah, I would say that the major thing is make sure that you're doing it on a yearly and consistent basis. It's very important. It's probably one of the most important things that you can do, to ensure your practice's viability. Again, no business can continue existing if it's losing 5% of its value every single year and doesn't do something about it. So, whether you work with us, whether you work with a consultant, whether you do it yourself, just make sure that you are consistently negotiating your rates every single year.
Nathaniel, thank you so much for being on your wealth of information. We'll have you come back and we'll do another one, maybe a deeper dive where we use these questions we weren't able to get to cover. But for those of you who answered questions, we appreciate it. For those who didn't get their questions answered, we'll create a document and we'll send it out to you after the webinar is over. We will send you a recording of this session along with the slides from the deck. And we're grateful to have you with us today, and we're grateful to have Nathan helping us. So in the meantime, take care, keep fighting the good fight, and we'll see you on the next one.
Thanks. Thank you for having me.
Bye-bye.